Good afternoon. I'd like to welcome you to the session number 1, Fungal Infections and Cystic Fibrosis. And I'm really excited about the lineup of talks here that focus on both the pathogen side and the host side on these types of infections that are really not well understood in terms of how to identify them, how to treat them, and to understand what their consequences are in different aspects of CF care. So without further ado, we're going to start with our first speaker, who is Jane Jones, a research scientist in the lab of Robert Kramer at Dartmouth. The Kramer lab and Jane Jones works in the Dartmouth Cystic Fibrosis Center, DART-CF, and she's going to talk about her work in understanding how ETI affects the pathogen Aspergillus fumigatus.
Okay, thank you very much for the opportunity to speak here today. Again, my name is Jane Jones, and I am a research scientist in Rob Kramer's lab at Dartmouth. The title of my talk today is The Cystic Fibrosis Treatment Trikafta, or ETI, Affects the Growth, Viability, and Cell Wall of Aspergillus fumigatus biofilms. And I have no disclosures. Okay, up to 80% of people with cystic fibrosis test positive for fungus, with the most common being Candida albicans and Aspergillus fumigatus. Aspergillus fumigatus can contribute to various CF-related diseases, including asthma, bronchitis, aspergillomas, invasive pulmonary aspergillosis, and ABPA. And so upon initial colonization, patients can begin to develop CT abnormalities. And then as time progresses, the colonization can progress into an infection, which leads to actual damage, and that can, again, further progress into ABPA and bronchiectasis. And so in the current age, we need to think about how highly effective modulator therapies impact how we treat Aspergillus fumigatus and cystic fibrosis. And so interestingly, a few publications in the last few years have shown a reduction in fungal species in the lung with CFTR modulators. And most recently, this last paper I show, they published that Trikafta can actually reduce Aspergillus fumigatus in patient samples. And so when thinking about how restoration of mutant CFTR function can impact this phenotype that's been observed, there's mucociliary clearance, the inflammation in microbiology, and then changes in overall lung function and structure. And so for today, we're going to focus on how restoration of CFTR function can impact inflammation and microbiology within the lung. And so a few years ago, when we started coming across these papers in the literature, we decided to determine if we can actually recapitulate this observation in mice in our hands. And so we began with just a pilot experiment where we used wild type and CF mice, and they were treated 2 times with Trikafta oropharyngally, and then they were inoculated with Aspergillus fumigatus using a laboratory reference strain, CEA10. And so our endpoint was simply to measure colony-forming units from lung homogenates, just to see if Trikafta had any impact on Aspergillus that we could recover from the lung. And what we actually observed with it was that in both wild type and CF mice, we observed a slight reduction in colony-forming units in the Trikafta-treated animals. And so this gave us more justification to pursue this question. And so when thinking about why or how highly effective modulator therapies can affect Aspergillus in the CF lung, we kind of came up with 3 different hypotheses. The first is that Trikafta affects the growth or biological properties of Aspergillus fumigatus itself. The second hypothesis is that Trikafta alters mucociliary clearance and inflammatory signaling or immune cell function in the host, and this could be CFTR dependent or independent. And then the third hypothesis gets more complicated, where Trikafta could be affecting both host and fungi. And so we're going to focus on this first hypothesis for the talk today, in which Trikafta can actually affect the biology or function of the Aspergillus fumigatus itself. And so we do have data or rationale to support this hypothesis. We've identified a total of 8 CFTR-like genes in the Aspergillus fumigatus genome. And what I'm showing here is a predicted protein structure of the most similar CFTR-like gene, but actually has a predicted putative CFTR in Aspergillus fumigatus with ABC transporter activity. And so we thought it's very likely that this could be a potential target or several targets of Aspergillus fumigatus for this Trikafta. And so this leads us to our major questions for the project. Does Trikafta impact the growth or viability of Aspergillus fumigatus? And if so, can Trikafta then be leveraged as an antifungal or be used in any kind of therapeutic setting in Aspergillus fumigatus colonization or infection? And to first address this question, we used a classic minimum inhibitory concentration assay, which is how you test conidial antifungal susceptibility. And so in this assay, we simply inoculate a 96-well plate with resting conidia, and then we perform a serial dilution of the antifungal or drug that we want to test. And we we grow the aspergillus in the presence of drug, and we simply look for growth or no growth of aspergillus. And what we found was that there was absolutely no impact with Trikafta. And so I want to mention here that this is a very binary assay, so either growth or no growth. And so we were thinking, okay, what do we do next? So when thinking about Aspergillus fumigatus and how it presents within the actual lung, in the environment, it sporulates, and then a person can inhale the spores and they become deep within the airway. And then that presence, or if in the airway, the conidia can then germinate and grow into these hyphal or biofilm structures in an immune compromised or a CF patient. And data to support that, we also observed this hyphal structure and in a respiratory sample from a patient with CF. And so this actually supports that we're potentially looking at the wrong morphotype of Aspergillus fumigatus to test. And so in order to address this question, we decided to use a submerged Aspergillus fumigatus biofilm model to recapitulate what we see about biofilms in vivo. And so in our model, we inoculate plates with Aspergillus conidia in a glucose minimal liquid media, and they're allowed to grow for 12, 16, and 24 hours. And hopefully you can see by 24 hours, the biofilm structure is very similar to what is observed in a mouse model of aspergillosis and what you can see in the image to the right. And so using this model, we chose to grow biofilms for 16 hours in our glucose minimal media, and then removed media and treated them with either our vehicle control or Trikafta for an additional 24 hours. And we tested this in both common laboratory strains as well as CF clinical isolates. And what I hope you can appreciate is that in all of our isolates that we tested, Trikafta reduced the growth in every single isolate and all of our laboratory strains. And when we quantified biofilm biomass, we observed anywhere between 80 to 40% reduction in biofilm biomass. And so next we wanted to determine if this was dependent on ion channel activity because, as we know, Trikafta targets CFTR function in mammalian cells. And so when we treated our biofilms with Trikafta, we treated them in the presence of GlyH101, which is a mammalian CFTR inhibitor, and we also treated them in the presence of verapamil, which is a calcium channel inhibitor. And so what we observed was that, especially with GlyH101, we saw almost a complete reversal of the biofilm biomass phenotype and a partial reversal with verapamil. And in parallel, we chose to treat biofilms with amphotericin B, which is a very potent antifungal. And you can see that the GlyH101 and verapamil did not rescue the biofilm biomass defect. So this suggests that Trikafta is reducing biofilm biomass through ion channel activity. And so we've shown so far that Trikafta reduces biofilm biomass, but does it actually directly impact the viability of the biofilm? And this is actually a difficult question to address. So we developed a new assay to do this. And so we call it a biofilm regrowth assay. And so this can actually quantify viability of a biofilm after drug treatment. And so in this assay, we grew biofilms for 16 hours and then treated them with drug for 1, 6, or 12 hours. At that point, we collected baseline samples, And then in parallel biofilms, we removed the drug and allowed them to recover in media for 24 hours. And then we collected our recovery sample. And the data I'm going to show you is the recovery divided by the baseline sample to look at the fold recovery of the biofilm. And so what we've observed is that actually even with 1 hour of treatment with both either Trikafta or amphotericin B, we saw a significant reduction in the ability of the biofilm to recover from drug treatment. And then when you take it out to 12 hours of treatment, we saw virtually no recovery. So this data not only shows that Trikafta is reducing the biofilm biomass, but it's reducing its viability. And so we've observed that Trikafta in and of itself has antifungal properties, but we also wanted to ask the question, does Trikafta improve the efficacy of commonly used antifungals? So I showed amphotericin B in previous slides. That is a very potent antifungal with very severe toxic side effects. And so we wanted to explore the potential synergy with either azoles or echinocandins. And I won't go into the data today, but Trikafta did not have an impact on how azoles damage biofilms. And so for the purposes of today, I'm going to show you data that shows that Trikafta improves the function of echinocandins. And so echinocandins are antifungals that target the fungal cell wall. And so they actually inhibit the beta-1,3 glucan synthase, which is an enzyme that generates beta-1,3 glucan, which is a critical component of the fungal cell wall. It is the only non-toxic antifungal, and it's used, though, as salvage therapy because it's fungistatic and not fungicidal. And so we used an assay, a metabolic activity assay, to ask the question if Trikafta impacts how caspofungin, which is a common echinocandin, impacts or causes damage to Aspergillus fumigatus biofilms. We chose this assay because at a low dose of caspofungin and Trikafta, we don't see any impact on the biofilm while they're individually treating the biofilms. So we wanted to see if together we could observe any synergistic activity. And so we treated biofilms for 3 hours with either each drug alone or in combination, and we measured metabolic activity. And so what I'm showing here is that caspofungin at the dose we chose caused absolutely zero damage to the biofilm. So you see a 100% metabolic activity in the presence of DMSO, which is our vehicle control. But in the presence of Trikafta, it nearly completely obliterated metabolic activity. So this was very exciting data for us, and I'm going to expand on different endpoints to measure damage in a little bit, but I also wanted to mention that since Trikafta is altering a biofilm response to an echinocandin, and that suggests that Trikafta also alters the cell wall of the biofilm. And so since the cell wall is important in eliciting an inflammatory response from the host, we wanted to test if Trikafta altered the inflammatory environment in co-culture with Aspergillus and host cells. So to address this question, we isolated Aspergillus fumigatus canidia in parallel with both wild type and CF bone marrow cells. We put them in co-culture with vehicle control or Trikafta for 16 hours. And then we collected the supernatants and measured TNF-alpha, which is a pro-inflammatory cytokine in the supernatant. And what we found was that Trikafta significantly reduces TNF-alpha secreted by bone marrow cells in both wild type and CF mice. So this suggests that Trikafta is modulating the inflammatory response of host cells to Aspergillus. And so to expand on the observation that Trikafta is causing changes in the cell wall and altering the biofilm response to echinocandins, we decided to then screen several CF isolates to see if this phenotype held up. And so using a select group of CF isolates, we observed that Trikafta increased synergy or caused synergy between echinocandins in 5 out of 6 of the isolates that we tested. And so to expand on this observation, we chose to move forward with isolate AF110.1 because you can see it had a very potent synergy with Trikafta and caspofungin, but caspofungin alone did not cause much damage, if at all. And so we next wanted to test if Trikafta could exacerbate the biofilm biomass reduction caused by echinocandins. And so we co-treated biofilms with Trikafta and either caspofungin or micafungin, which is another echinocandin. And we see that, yes, in fact, caspofungin is also exacerbated in the presence of Trikafta by a biofilm biomass. And then finally, the last endpoint we wanted to test was adenylate kinase release. The main mechanism of action of echinocandins is that it causes hyphal tip lysis. And so a way to measure this is to look at adenylate kinase released into the supernatant because adenylate kinase will be released in the presence of a lysed hyphae. And so we again co-treated biofilms with Trikafta and echinocandins. And we observed that, particularly the caspofungin, we observed a strong synergistic release of adenylate kinase with Trikafta and caspofungin as well as micafungin. And so to summarize what we've shown so far, Trikafta in and of itself reduces biofilm biomass and viability. And Trikafta also increases susceptibility of Aspergillus biofilms to echinocandins. And so what we really want to know is how can we leverage these observed phenotypes for therapeutic relevance? And so going back to our original assays that we did, we screened several Aspergillus fumigatus isolates for biofilm biomass phenotype. And actually this particular isolate, AF106-610, had the highest susceptibility to Trikafta. And then when I tested it in the biofilm viability assay, we also showed that this isolate was susceptible to Trikafta viability reduction. And so we decided to move forward with this isolate for our next question. And so we next wanted to test how effective is Trikafta against strain AF106-610 as well as a reference strain in a CF relevant media. And so in order to do this, we were very fortunate to be in the lab next door to a lab that has a perfect setup to test this. So in George O'Toole's lab next door, they have a polymicrobial community preparation to mimic the CF lung environment. And this was pioneered by Fabrice Jean-Pierre. And so the O'Toole lab discovered that there were 4 main bacteria within the CF lung environment: Pseudomonas, Staphylococcus, Streptococcus, and Prevotella. And so they grew these up in co-culture in artificial sputum media and incubated them for 24 hours. And then after a series of centrifugation and isolation, we were able to have a filter sterile supernatant to mimic the CF lung environment. And so I next grew up both CEA10 and AF106-610 biofilms and treated them with Trikafta in the presence of our glucose minimal media, which is on the left, artificial sputum media in the middle, and then the polymicrobial supernatants. And what I hope you can appreciate from these graphs is that Trikafta is effective in any media condition that we have tested here. And then when I quantified percent of the vehicle control, we see there's virtually no difference between any of the media conditions. So Trikafta is effective in our laboratory media as well as media relevant to cystic fibrosis lung. So this was very exciting to see. And so, the next obvious question is how can we test this in vivo? And this is very much a work in progress right now. But we decided to go ahead with pharmacokinetic studies to really get the dosing strategy down for administering Trikafta. And so we collaborated with Dr. Michael Cameron at UF Scripps, and he performed pharmacokinetic studies with Trikafta. And firstly, Trikafta caused no observable morbidity in mice that were injected. And so he tested for 4 days in a row of Trikafta at 10 mg per kg. And on day 4, he did a time course of subsequent blood draws. And all 3 modulators were quantified over a 24-hour period. And what we observed initially was that elexacaftor in particular had a very strong half-life. And so if you look down here at the bottom, by the end of 24 hours, elexacaftor is reaching the dose used in vitro. And this is really important because data I haven't shown you before is that actually elexacaftor or VX445 is the modulator that primarily drives the biofilm biomass reduction with a little bit of help from ivacaftor. And so this is really exciting with our studies moving forward. So this suggests that there will be sufficient levels of elexacaftor in our experiments. We'll potentially do a second dose of ivacaftor as well, because I think that has a modest impact. Tezacaftor hasn't had any impact in and of itself in any of our assays, And so how can we really test this in vivo? We want to go back to our mouse model. And so the data that I showed you in the very beginning of the presentation was in an immune competent mouse model. And so mice are inoculated with Aspergillus fumigatus, and they do not reach the hyphal or biofilm stage within the lung. And so since we see that Trikafta has the strongest impact against biofilms, we wanted to test this in a biofilm model in vivo. And so in our model, mice are injected with Kenalog, which is a steroid, which causes immune suppression. And then they are inoculated with Aspergillus fumigatus. We would first use a lab reference strain, but as well as other clinical isolates. And this would allow for a biofilm to form within the lung. And then in doing so, we can test endpoints like histology, fungal burden, immune cell infiltration, inflammatory cytokines, as well as morbidity and mortality. And then I think most importantly, we can use this model to explore Trikafta in combination with the echinocandins and really explore this synergy we observed in vitro in vivo. And so to summarize, what I've shown you today is that Trikafta has morphotype-specific antifungal activity in vitro. We've also seen that it reduces the growth of Saccharomyces cerevisiae and Candida albicans. I didn't have time to go into that data today, but there is potential for broad efficacy. Trikafta enhances the antifungal activity of echinocandins in vitro, and we are currently testing the impact of Trikafta against biofilms in vivo. And so I'm going to end on a question. Is Trikafta's antifungal effect the reason we are observing less fungi in CF samples? I don't know. And with that, I just wanted to thank my PI, Rob Kramer, and all the people in the lab, and then especially our collaborators, George O'Toole and Michael Cameron. Thank you.
That was a fantastic talk. We now have time for any questions. I'd love to start things off. I'm curious if you have seen any dose dependence in your ETI synergy with the echinocandins that might make you think about when to time the administration of ETI with respect to an antifungal therapy.
Yeah, I didn't show the data here, but we did do checkerboard assays on the biofilms. We did kind of a modified checkerboard assay where we had a serial dose of each drug on the y-axis versus the x-axis, and we did see a dose-dependent synergy for sure. In terms of informing that in vivo, I think the first thing that we're doing, I'm actually doing this next week, is I'm going to be dosing animals with a few doses of mycofungin in vivo and see. The hope is that at a low dose we won't observe any impact on the fungal burden itself, and then with a higher dose, as a good positive control, we will. And if that's the case, then I'll use that in combination with Trikafta. We still have more experiments to kind of find that sweet spot with Trikafta in vivo, but there's a lot more known about the dosing that we can use for echinocandins, but we just kind of have to fine tune it to our steroid model with our lab reference strains in our hands. So, but yeah, we're very close to being able to explore that in vivo. Yeah, so we use 5 micromolars for each modulator, and I remember, so I did a dose curve, and it was Trikafta basically had a nice dose response with regards to biofilm biomass. We saw there was an effective biofilm biomass reduction, I think all the way down to 1.25 micromolar, if I'm remembering correctly, but we were trying to go for the 50% reduction because that way, with our more mechanistic studies, which I'm not going into today, you can see if that kind of goes up or down depending on what we're testing. So we kind of wanted that sweet spot where we can use that as a foundation for mechanistic studies. But there is a very nice dose response with Trikafta. Yeah.
I have a quick question, if that's okay. I'm just curious about, so you have a cell wall. In terms of these getting into the cell, do you think it's necessary for the modulators to actually get into Aspergillus, or they can associate with some of these proteins in the cell wall itself to disrupt function?
Yeah, that's certainly a possibility. I did do some experiments with a transporter inhibitor, and that actually retained the Trikafta, or retained uptake. I think that it increased permeability, and so that it suggested that it was causing increased uptake. But I'm not sure if it's actually integrating with the cell wall. I mean, the ion channel experiments, the ion channel inhibitor experiments that I did would suggest that it's at least having an impact on the cell membrane, which is, internal to the cell wall. But we really don't know we haven't really addressed that question yet. But yeah, that's a good one. I think it might be the cell wall impact, I think could be potentially an indirect consequence of Trikafta modulating the cell membrane. I think that seems to be what the model is right now, but mechanistic studies are difficult because there are at least 8 CFTR-like genes within the Aspergillus genome. So we can't just knock one out and see what happens. There's probably multiple targets. So that makes it really challenging, but we have other ways to do it. So we're teasing that apart. Yeah.
Excellent. Well, if there are no other questions, please join me in thanking Jane. Great. And our next speaker is right here, Karsten Schwartz, who's the director of the CF Center at Health and Medicine University in Potsdam. Also a European CF Society board member and the leader of the fungal pathogen working group in that society. And today he's going to talk to us about immune responses to fungal infections and cystic fibrosis. Thanks, Karsten.
Yeah, thank you very much for the invitation. I think it's a really nice session already after the first talk. I have so many questions. I mean, at the end we will have a panel discussion, so I'm looking forward to that. Yeah, it's a rare topic and a rare disease, but I think I don't know, it's popping up, so I think it's not the end of the story right now, but we will see. So these are my disclosures. And yeah, I will only just touch shortly epidemiology of fungi in CF and entities of fungal infections. We just heard it, but there are some different definitions, I think, we have to note before we talk about the immune responses that are caused by them. So what we did in Germany, usually you only see the bacteria and the detection of bacteria. You wanted to know what's about the fungi, and we all know that that's usually Aspergillus fumigatus that we look at, and also sure Candida albicans is very common, but usually we will not treat this fungi. But what we also see, we can detect very rare species like Scytosporium or Exophiala. That's, I think, very important to know where to look at. And I think when we look also not only in cystic fibrosis, but since the COVID pandemic, I think there's a totally different knowledge about, but also awareness of fungi. That's why the WHO also now detected many fungi that are very relevant in general, but you can see that there are the fungus species that we also know from CF. So I think it's very good to know that we are working in a field that's very, very important, not only for CF, but also for other diseases. Yeah, what we wanted to know is there really an impact in general if we detect Aspergillus? If you look at patients, more than 5,000 here in the registry, with Pseudomonas and other fungi like Aspergillus, there's no difference in everyone, but if you delete them, so only look at the patients who are positive more than twice, so positive culture for Aspergillus, you see that there's a difference in FEV1. So there is an impact. I think there are much more other studies where you can see that we have to talk about fungi and the diseases that they can cause. Yeah, which entities are existing? I think we were always talking about ABPA, but we know in very rare cases we can also find aspergilloma, also pneumonia, bronchitis. Sure, we were talking about colonization and sensitization, and so there is maybe an infection and also an allergy part. And I think it's very, very interesting that we are not only talking about ABPA, but about other diseases. And the Fungal Pathogen Working Group of the ECFS was also working the last years to see how we can define it in CF, but also how to treat it. And only to give one definition for the pneumonia, because I think it's really difficult if we look at our CF patients to diagnose pneumonia that were caused or that are caused by fungi. And here you can see that we usually need to have detection of the fungus at least more than twice. And we know that our patients usually have no sputum anymore, because you said, yeah, there's a reduction maybe in Aspergillus because of ETI. I think it's a different story, but I think we can talk about it. And then, sure, usually we treat with antibiotics, and then we know if they getting better or not clinically. But most important, I think, is a CT scan, where you would find a typical infiltrate. Usually it's in the periphery, like you can see on those pictures. These are all CF patients that have a severe pneumonia due to fungal species. But now I want to come to the immune response in CF patients due to fungi. Why is it so important? I think it's very important because we are still at the beginning of understanding what we're looking at in cystic fibrosis patients. And with colleagues here from the States and also from Canada and from Europe, we wanted to know in this worldwide, I would say, study, what are they looking at if they are looking at fungi? So who is looking in the States and Canada and Europe for fungi? And you see that's a huge difference. And also, if patients are having a deterioration, not everyone is thinking of ABPA, of bronchitis, or of other fungal diseases. I think that's very important to know. And the other question is, which biomarkers are they using? And you can see there's a huge difference between the countries again, between Europe, between Canada, between the States. And I think everyone knows total IgE, but if it comes to fungus culture, not everyone is using it always. Also the Aspergillus-specific IgE and also Aspergillus IgG, which is very easy to test, to establish this assay, and very cheap, is sometimes really, like in Canada, in 9% almost not existing. So I think there's a need to think about what biomarkers are important, in particular when we're talking about patients who are on ETI, because they will not have this kind of vicious cycle anymore, because the mucus production usually is gone, and then the detection of fungal species is very, very difficult. Maybe it's easier for bacteria, but for fungal species, we know that there's a huge difficulty to test it. So that's why it's important to understand how the host is reacting. Usually we look at the B cells and T cells if we are talking about these different entities you can see here. And we want to have a closer look. What we did the last years, we wanted to know this very easy to use biomarker Aspergillus-specific IgG, so the antibodies, and to see if we can use it in our patients. And in this more or less 100 patients study, you can see that if you look at the Aspergillus IgG, that there is a difference if patients have an ABPA or pneumonia, because then you have an increase of the Aspergillus IgG. Usually in bronchitis, it might be elevated, but usually it's much lower. So it's similar to the control group, as you can see here. And if FEV1 in ABPA and pneumonia is lower than in the other groups, that's usually what we would expect. So that's a very easy marker, and here you can see it on a different graph in this figure again, that for ABPA and pneumonia, you can use this very simple B-cell antibody marker to detect those kinds of biomarkers and diseases. So not only to diagnose it, but we use it also to follow up. So it's very important if you're generally using it at the beginning of the therapy. You can nicely see for ABPA, if you put pneumonia, and also for bronchitis, that you see a decrease of this biomarker. So I think it's very easy to implement and very easy to have. And then in the study, we looked at the cutoff level, and it's similar to what the companies suggest, but there were no really big studies about the cutoff. And so the cutoff is more or less at 75 with a specificity and sensitivity of 75, which is quite okay, I think. And as we not only detect Aspergillus, what I said before, we also have other rare fungal species like Exophylla or Scedosporium. We wanted to know if we can use this very easy to have IgG biomarker also in Exophylla infections. And here you can see if you don't divide the group, so if it's maybe only a short colonization, you detect it once, there will be no answer. But if there's a real infection, you can see with the Exophylla or anti-Exophylla IgG, you can distinguish between an infection and also patients who are not infected. So it's also not only for Aspergillus, but for Exophylla working well. And only just to show that not always the sputum culture will be positive, but you can see that in this patient, the IgG is always high, and after treatment, it will decrease. And again, we have many patients who are not producing any sputum anymore, so we need other biomarkers to detect infections for bacteria, but also for fungal diseases. Yeah, coming back again to the different entities we are looking at. So we had the B cells, now we want to look at the T cells. What can we learn from the T cells? What are they telling us? So just in general, we're detecting or doing this antigen-specific T cell enrichment, as say, already for more than 15 years. And here you can see the difference between healthy people and between CF patients in general. So we know that most of the patients with CF, they will have a Th2 response. Yeah, the host will respond to Aspergillus with a high Th2, but which is very interesting. Not only there's an allergy response, but there's also kind of a infection response. So the Th17, Aspergillus-specific Th17 is high, and that's totally different if you compare it with healthy patients, with healthy people, and not with the patients. Yeah, and then the question is, if they are so strong responding to allergy, if they are colonized or infected with Aspergillus, what is the fraction they are responding to? So that was not known for no patients, also not for other asthma patients. And we looked in the lab and found that's neither the membrane fraction nor the cytosolic fraction, but it's a secreted fraction. So the secretion that is causing the allergy in patients with CF. So they are causing the Th2 response against the secreted fraction. So that's a totally new knowledge we have now. So that might also give us some more ideas, maybe also for you, how to diagnose Aspergillus or also to treat it. And then in a pilot project already 4 or 5 years ago, we could show that in acute ABPA patients, that's now the part of the ABPA, that IL-17 is able to distinguish between acute ABPA and between chronic ABPA and ABPA history and also ABPA that is treated. Because usually you have this high Th2 response, which is more or less stable even though you're treating the patients. And as we could see that this might be a very good marker, after this pilot project, we were able to get funding for a prospective ABPA study and wanted to know what else can we see in our patient when we compare acute ABPA patients and the response of the immune system compared to patients who have an exacerbation with sensitization to Aspergillus, but without an ABPA with the classical biomarkers you use. Yeah, that's only the things we studied. So we had 77 patients that were sensitized with exacerbation, and we had 71 patients with acute ABPA that were untreated. And so we wanted to know if there's a difference. So just in general, it's similar to what I just showed before in our other study, that the Aspergillus-specific IgG is very high in ABPA patients. It's really a good marker, I have to say. Sometimes you only need this marker to detect an ABPA, in my opinion, compared to treated patients or also to the control group. And also total serum IgG, we would expect that is highly elevated. And also the specific IgE. But that's known, that's nothing new. But then if you look at the interferon gamma for Aspergillus fumigatus, you see that is more or less low in the acute ABPA patients that are untreated compared to the other groups. And IL-4 is elevated again. And most important, and that's very interesting, is the Ki67, which is a proliferation marker for T cells. So shows that there is a very active growth in the Aspergillus, which is very high compared to the other groups, so that can distinguish between these different entities that are shown here. And then it was the aim to show that IL-17 is elevated in the acute ABPA patient, and that was not significant. And we followed up all the patients as they are from our center, and we could see that we missed in the control group 6 patients that were having already an ABPA, so the classical markers were positive afterwards. So we can also conclude at that point already that IL-17 is an earlier marker than the classical markers we are usually using in our patients. And then IL-21, the next in the middle, the graph, it's also elevated in acute ABPA patients, which also shows beside the effect of an allergy, the infection. So that's maybe something we have to keep in mind, because we think that the infection part might destroy the bronchi and the lung tissue, because after not treating ABPA, 2 months or 3 months later, you will see new bronchiectasis. So it's not the allergy usually, but the inflammation that is causing the damage. And here you can more or less prove it with the antigen-specific T cells. Yeah, and then bronchitis, another entity, sometimes hard to define, because there are many patients colonized with Aspergillus. You never know, is it now a bronchitis or not? Yeah, which marker to use. In the bronchitis, so it's more or less the opposite. The interferon gamma is quite high compared to the other group. So that might be a marker that is caused in bronchitis. Maybe if you're looking on the long run, maybe bronchitis is then changing into pneumonia if you don't treat it. So that might be something explaining the difference in our patients. Yeah, and pneumonia, can we see anything in the pneumonia cases? Here are again CF patients with severe pneumonia caused by fungi with Aspergillus and also Scedosporium. And so in those different patients, we also looked at the T cells, so how is the host responding? And we could see for Aspergillus as well as for Scedosporium that IL-17 is highly elevated. So the frequency of the T cells is really going up to the roof in both cases. So that's a very good marker that is directly connected to those patients. Yeah, and right now we are always thinking about what you just said in your first talk. How is ETI influencing the bacteria and the fungal infections? And so we looked at our patients in terms of the T cell response to different bacteria and also fungi. Again, first we wanted to see just the general markers again. IgE is dropping after ETI, which is interesting. So the allergy part is decreasing. They have less sputum. One could think, okay, there's less antigen, and also the inflammation with the general IgG is significantly lower. So both parts is something we can realize that's happening with our patients when they have less sputum. But in all different bacteria and fungi we looked at, so Scedosporium, Candida, Aspergillus, Pseudomonas, and Staph aureus, we could see that the Ki67, which is the proliferation marker, again, from the T cells, is decreasing. On the right side, on the spider graph, you see that so pre-ETI is outside, and inside is with ETI, with the treatment, the patients responding much, much less or lower to the bacteria and to the fungus than before. So the question is, yeah, there's less sputum. Is that the question? Or is maybe ETI destroying not only fungal species, but also bacteria? So it was very interesting to see the first talk about it. So yeah, we can discuss it later, I think. Yeah, so at that point, fungi are still relevant pathogens in CF, and I think it's a very, very easy to use marker to use IgGs for Aspergillus, for Exophiala, and not only for diagnosing, but also to show the response to our treatment. And then Aspergillus-specific interferon gamma might be elevated in Aspergillus bronchitis, so that might help us to understand if the patient is only colonized by Aspergillus or maybe have a bronchitis. Then IL-17, the Aspergillus-specific IL-17, and Ki67, the proliferation marker, is an early marker that is elevated in ABPA. and in some cases earlier than the normal used and markers for diagnosing ABPA, such as IgE, for example. And Aspergillus and Scedosporium specific IL-17 is elevated in pneumonia, so there's a severe reaction of the host. That's why you can see all this huge infiltrates, and the question is if they are in the future gone or not. We still see pneumonia due to fungal species, but I think that's part of the discussion. And yeah, and the question is, when we see that IL-17 is elevated, is it maybe a possibility to treat during pneumonia or during ABPA? Yeah, together with antifungal therapy. And it's interesting to see that with ETI, the T cell frequency in general is decreased, so the proliferation is decreased, and that might be also a hint to the first talk we heard that maybe ETI is really killing Aspergillus. So that's very interesting. And I think as we have almost no patients on ETI with sputum, it's very important to have immune response to infections for the future as diagnostic parameters and also for therapy. And in the end, I want to show you that also antifungal stewardship is now existing, not only antibiotic stewardship. I think it's very important. That's why I really enjoy this session here today. I want to thank all the people that were working together in Canada and the States, in Europe and Australia. I also want to thank my team, and I want to thank you for your attention. Thank you.
Great. We have some time for questions.
No, that's a very good point and a very important point, because we did the same before. We were asking the patient. I mean, it's always good to ask a patient if he's getting better or not. No matter what biomarker you have, if it's going down, the patient said, no, I'm feeling still not good. Yeah, exactly. So when I don't know, started to do research in infections, I was told that these IgG markers are very unflexible, very slow decreasing and increasing. And when we started our research, we saw that they are not very unflexible, they're very flexible, they are responding very quickly. So we did also ask the patients, how is it? And then we looked into our data, because we were always using these IgG assays. And then we just find out, wow, it's a very good biomarker. So we didn't know that before. So for us, always there were other markers like the infiltrate, if we have a pneumonia, to see if it's decreasing, the IgE in ABPA, a specific IgE. So that was an additional marker. And right now, as we do it now for several years, we see it's getting stronger and stronger with that marker. And the question is, so if the patient is getting better and you only treat it with antifungal therapy and the antibodies are staying high, the question is, did you look at it before? Were they always high? Then maybe it is a patient who is still has contact to the fungus, because that's what we see, for example, in ABPA patients who are not responding. They have, for example, fungus in their kitchen or in the bathroom. So I would ask if they still are confronted with the fungus. Yeah, but I also would then first stop the treatment if the patient gets better. It's a matter of question how long you would treat it. Bronchitis exophiala, we usually recommend 2 to 4 weeks, not longer. But yeah, that's a decision of the clinical response. Yeah, but very important question.
I'm curious about other consequences of the Th2 type response that you see in that cohort.
Yeah.
Are there any correlations between specific bacterial pathogens, anti-correlations or positive correlations in the cohort that has that response?
Yeah, I mean, that's specific for Aspergillus, the Th2 response. So it's very high. And so we tested also before a COPD patient, asthma patient, and then CF patients, normal human beings. And it's nowhere that high as in CF patients for Aspergillus. So it's mainly Aspergillus. Yeah.
And there isn't a difference in other pathogens like Pseudomonas?
Yeah, I mean, people always ask, might there be allergy to Staph aureus, for example, Th2 response? We were looking at that, but it's below 1%, also for Pseudomonas. So it's mainly the Aspergillus, also Candida, yeah, it's described, but we never saw anything like that. Yeah. Also for Scedosporium, yeah, like these ABPM, a lot of discussion about it. But it's very rare, I have to say. And in our cohort, we didn't see any of them. The rate of ABPA, okay. Yeah, I mean, we did this study. We thought, okay, can we still do this study when patients are on ETI, and we still see many patients with ABPA who are on ETI. So, yeah, for me, the question is, I mean, maybe we discuss it at the end. I think we still see ABPA and also other fungal infections or entities, and later on maybe we can discuss why we might see it. Maybe in the far future when the lung is really healthy, if children now start with ETI, we might see less, but right now with the older patients, we still see them, yeah.
Excellent. Well, please join me in thanking Karsten for a really wonderful talk.
So it's my pleasure to introduce the speakers for the second half of this session. So next we have Lauren McGee from Virginia Commonwealth University. So we're going to change things slightly. So this is going to be from a pharmacist's perspective, understanding specifically antifungal treatment implications in CF.
All right, thank you for the introduction. Just as a disclaimer, this is an educational session. This is my interpretation of the literature and not necessarily that of the Cystic Fibrosis Foundation. And I have no relationships to disclose before we start this presentation. As far as learning objectives for today's session, I'd like to describe the spectrum of activity and tissue penetration of antifungal agents from different classes, to then review pharmacokinetic and pharmacodynamic properties of the triazole antifungals, and then identify monitoring parameters for triazoles based on their adverse effect profiles, their significant drug-drug interactions, and then therapeutic drug monitoring thresholds. Okay, as Dr. Swartz just mentioned, there is debate as to whether we treat these infections or we consider it colonization. And it's been proposed that we may consider treatment of an active infection if the patient's grown this particular isolate more than one time within the course of 6 months, if we've treated them and with 2 courses of antibiotics for longer than 2 weeks, but yet they still have imaging that suggests that there is an infection that's there. And also you've ruled out other causes. There's not other bacteria that's growing. You don't think this is ABPA that's causing it. In these patients, we may consider treating them as if they have an active infection. Also, as previously mentioned, there are a few organisms that we need to be mindful of when it comes to fungal organisms. Things to consider is the pathogenicity versus the chronicity. And if we start first with the pathogenicity, that's going to be the ability of an organism to cause a disease, whereas chronicity is how long has that disease been active for a patient. And so I have the image here along the x-axis. If we start with chronicity, it goes from low to high, and then the y-axis, pathogenicity, unknown to established. If we start with high chronicity organisms that we aren't certain if they're really causing disease, the one we think about the most is Candida. It's not uncommon for our patients, but anyone in general, to have their respiratory tract colonized with Candida species. However, if we consider those with high chronicity and we know that they have the ability to cause disease, the ones we think of most commonly are Aspergillus and Scedosporium. So next, what we have to consider is, are all antifungal agents created equal? And we're going to look at spectrum of activity. So here along the top, I have the different antifungal organisms that we have available currently in the United States. So we have amphotericin, fluconazole, itraconazole, voriconazole, posaconazole, followed by the echinocandins, aningulafungin, caspofungin, and mycofungin, and lastly, flucytosine. We're going to start in the middle with the Candida species that we talked about a second ago, high chronicity, but the pathogenicity we're not certain of. And as you can see here, there's a lot of plus signs there, plus signs indicating that these antifungal agents cover the organism in question. So across the board, all of them at the moment have empiric coverage against Candida albicans. Candida krusei and glabrata are a little bit different. There's some intrinsic resistance there with fluconazole and itraconazole. But as we move up the chart and look at Aspergillus, and there's a bunch of different species there, you see that some of that coverage falls off. So no longer can we rely on fluconazole or flucytosine to cover for Aspergillus. We'll have to think about some other medications. Now, just because there's a positive sign there does not indicate that it is necessarily the drug of choice. And we're going to talk about treatment options and if they are the drug of choice, first line or second line therapy. So keep that in mind. Just because it can cover an organism doesn't necessarily mean that we use it empirically as a first line option. And then when we get to Scedosporium, you see there that a lot of those plus signs have now disappeared and turned into negative signs or minus signs. And so the medications that we consider the most robust in coverage against Scedosporium is going to be voriconazole and posaconazole. Now, the other things that we have to consider is penetration. So are we getting to the location of the infection? And so here the chart is flipped the opposite direction. I've got all of the medications there listed in that first column. But here I'd like to focus in on the lungs. So we've got three different areas: the tissue, the alveolar cells, the epithelial lining. And here we have, if it's marked in green, then the concentration of the antifungal agent is robust there in that particular location. If it's yellow, it's got intermediate concentrations. In red, their concentrations are a little bit low. X indicates information from human patients, whereas the O is from animal information. Here, to be honest, my takeaway point is that for the most part, we can count on all of these agents to penetrate the area of interest if we're concerned about Aspergillus in the lungs. As far as management of Aspergillus goes, unfortunately, there's not any guidelines that are specific to patients with cystic fibrosis. There is the 2003 CFF consensus statement that discusses the treatment of ABPA. I've chosen not to focus on ABPA today, but more focus on aspergillosis. In that case, what we're left with is the Infectious Disease Society of America, or IDSA, their most recent update to the management of aspergillosis guideline from 2016. And in that, the mainstay of therapy is voriconazole, posaconazole, and itraconazole. Now, I do have one randomized controlled trial that is specific to patients with cystic fibrosis. Their objective was to determine if the treatment of Aspergillus colonization improved clinical outcomes. And as you can see here, they had 18 patients that were treated with itraconazole versus 17 patients who did not receive treatment with antifungal agents for a total duration of 24 weeks. And their primary outcome measure was to look at the patients that had an exacerbation that required IV antibiotics. And you can see here that 22% of the patients receiving itraconazole had an exacerbation that required IV antibiotics, compared to 31% that did not receive treatment. That is not statistically significant, most likely because of the small sample size. Now, they looked at another measure, which was the change in FEV1, and surprisingly, the patients that received itraconazole actually had a worsening of their FEV1 compared to patients that received, or that did not receive antifungal agents. So we do have conflicting results here. It may be for two reasons. One, it's a small sample size, and two, when they delved a little bit deeper, they looked at itraconazole levels, and they found that almost 50% of their population had not received adequate therapy in coordination with the therapeutic drug monitoring. So in that setting, again, we don't have that much information available specific to patients with adult CF. I think you're going to have to consider what some of the benefits of treatment are along with the risk. And when I talk about risk, I do mean their adverse effect profiles, their drug-drug interactions, and then also the development of drug resistance if we give patients medications that they might not need more frequently. As far as pharmacokinetics and pharmacodynamics are concerned, this chart is limited to the triazole antifungals because we are using them more for Aspergillus than we are for the other agents. So we've got fluconazole, itraconazole, voriconazole, posaconazole, and isavuconazole. And here, some of the things that I wanted to discuss was bioavailability. So how much of the drug that are they absorbing into their systemic absorption? And here you can see that most of them are in the 90 percentile. So that means that whether I give them drug orally or IV, they're going to absorb nearly the same amount. And this is after the medications pass through their GI tract, it's gone through first pass metabolism. Whereas itraconazole and posaconazole, those numbers are not in the 90s. And we'll talk about that in a subsequent slide. That might be due to the absorption of, or the impact of food on absorption, and also acid suppressing medications. As far as protein binding is concerned, I think the thing to consider here is that drug that is bound to protein, whether that's albumin or another protein in their body, that's not the active drug. It's the free drug that is roaming about that has the therapeutic effect. So if you have patients with low albumin stores, they might have more drug concentration that is free in their system and that is available compared to other patients. The other thing I wanted to touch on was metabolism. So I know there's a lot that's going on in this particular column. They are metabolized, the triazole antifungals, through the liver. The reason I have all of these different CYP organisms or CYP substrates on here, whether they're inhibiting or they are a substrate of that CYP, is because it ends up causing significant drug-drug interactions. And we are going to focus a little bit on Trikafta in a later slide. As far as half-life is concerned, most of them are around that 24-hour mark, and that will be important when we talk about therapeutic drug monitoring. And renal dose adjustments, there really aren't too many of them. Fluconazole does require renal dose adjustments if the creatinine clearance is less than 50. However, voriconazole and posaconazole don't require dose adjustments, but you do have to consider if you're giving them the IV formulation that there is a vehicle in that formulation that can cause nephrotoxicity. As far as adverse effects of triazoles are concerned, so all of them can cause hepatotoxicity, all of them have the potential to cause photosensitivity. The vast majority cause QTc prolongation, with the exception of isavuconazole, and sometimes we use this for its unique properties of causing QTc shortening. And then they all can cause neurotoxicity. I think the one that we are most concerned about oftentimes is voriconazole and the visual disturbances or hallucinations that come with it, mostly at high drug concentrations. So for this reason, the things that we monitor for the triazole antifungals are liver function tests and therapeutic drug monitoring. As far as therapeutic drug monitoring is concerned, fluconazole and isavuconazole do not have therapeutic thresholds that are in place, but itraconazole, voriconazole, and posaconazole do. Now, the timing of the drug levels are very much dependent on what their half-life is. Usually we say it takes 4 to 5 half-lives to reach steady state, so that's why we have this window of around the 5 to 7 day mark as being the most appropriate time to draw levels. And each one of those does have a corresponding trough range to target, and then you'll notice here that voriconazole does have an upper limit of normal where we start to see toxicities if the levels range of 5 or higher. Now, there aren't guidelines that talk about how or what to do with that information as far as, if you get a level that's low, how much you should increase by. But I do have here one institution's dosing guidelines when it comes to voriconazole, and this is for cancer patients in particular. And I think the thing to take away from this is that we have to then start thinking about logistics and what tablet sizes voriconazole is available in. And if we need to, we're going to be limited by dose increase based on that increment. So here you see increments of 50 milligrams is how they did their titrations. And of course, anytime you start giving doses that are outside of the normal dosing range, you introduce the propensity for having prior authorizations from the insurance company. So always keep that in mind if they're not already there in the first place. As far as some drug and food interactions are concerned, so fluconazole, voriconazole, and isavuconazole do not have, or food and acid-suppressing medications like protein pump inhibitors and histamine receptor antagonists do not impact their absorption, but that is not the case for itraconazole and posaconazole. I also want to point out here that not all dosage forms are created equal. So when we look at itraconazole, if you're taking the oral solution and you take that with food and it may be even your tube feed, that's going to decrease the amount that gets absorbed. Whereas if you're taking itraconazole capsules, you actually want to take them with food to help boost the absorption. When it comes to acid suppression medications for itraconazole, if you're on the oral solution, it doesn't really matter if you're giving it with an acid suppressing medicine. But if you are taking the capsules and you are on something like a proton pump inhibitor, it is going to decrease the absorption. Yet when we get to posaconazole, the opposite is true when it comes to acid-suppressing medications. So if you're on the oral suspension, it is going to decrease the absorption, but their delayed-release tablet, it doesn't have an effect. So hard to commit this to memory, but do consider that food and acid-suppressing medications do have the potential to have impact on some of these triazole antifungal absorption. As far as drug-drug interactions are concerned, I would absolutely encourage you to use whatever drug information checker resource that you have to run it against a lot of medications, but the one I wanted to focus on today is Trikafta. And so I have the image there at the bottom of just how the product is packaged, and this is for the adult patients because I solely deal with adult patients. So we've got, they take the 2 orange capsules, which is the combination of all 3 ingredients, the elexacaftor, tazecaftor, and ivacaftor in the morning, and then one of the blue pills, the ivacaftor by itself in the evening. But notice if they are giving it with a moderate CYP3A4 inhibitor, and I have those listed there at the bottom underneath of the table, so that's going to be fluconazole or isavuconazole, then we should instruct our patients to take 2 of the orange tablets on day 1, and then on day 2, take a blue tablet, and then keep repeating that. Day 3, 2 orange tablets, day 4, 1 blue tablet. There's no evening dosings that is associated with this. However, if we give them a strong CYP3A4 inhibitor like itraconazole, posaconazole, and voriconazole, the dose reductions are even more significant. So for these patients on day 1, they take 2 of their orange tablets. They don't take anything on day 2. They don't take anything on day 3, and they repeat that cycle about 72 hours later. All of their blue tablets are no longer needed because they're getting enough ivacaftor from the 2 orange pills that they're taking. Okay, so we talked a bit about the triazole antifungals. I focused in on them because per the IDSA guidelines for treating aspergillus or aspergillosis, those are the mainstays of therapy, the voriconazole, the posaconazole, the itraconazole. But what other options do we have? So we do have IV amphotericin that is available, and it's 3 different dosage forms. It is listed as a second-line treatment option, and again, that's in the IDSA aspergillosis guidelines. And oftentimes, we limit its use because it also has adverse effects associated with it: nephrotoxicity, electrolyte abnormalities, and infusion reactions. Now, I will say with the invention of the liposomal formulation, these adverse effects have decreased, but they are still present. As far as inhaled amphotericin goes, we do have a little bit of data that is specific to the CF patients, and this is for patients that were colonized with aspergillus. And we wonder if we treat them preemptively prior to receiving a lung transplant, if this will prevent them from getting invasive aspergillus post-transplant. And I've got 2 different studies here that looked at that particular question. The first study is there, those first 2 boxes off to the right, the left, by Luong and colleagues. And here there were 3 different interventions that were possible. Patients could receive inhaled amphotericin for an average of 12 days, voriconazole or itraconazole, and they did this for an average of 66 days, or patients did not receive any antifungal prophylaxis at all. And what they found was the varying rates of invasive aspergillosis following transplant. So the patients that received inhaled amphotericin, 3 out of 11 of those folks developed aspergillosis afterwards. If they received voriconazole or itraconazole, 10 of the 36 developed invasive infection afterwards. And if they didn't receive any prophylaxis at all, only 7 out of the 36 developed invasive infection. So again, conflicting results across the board. As far as the second study goes, this one was very real world and a little bit challenging to interpret. But from what I gather, the goal was that patients were to receive voriconazole 200 milligrams twice daily for 3 months. As with life, that didn't happen for all of the patients. So they had about 76 patients where that was their target, but 40 of those patients didn't receive treatment for that full 3-month duration, so they got broken down into a separate group. And then there were patients that didn't receive any antifungal prophylaxis at all. Of note, the ones that did receive the full 3 months of voriconazole treatment, there were a subset of those patients, 20 of them, who also received inhaled amphotericin around the same time that they were receiving the transplant. And here what they found is if the patients completed that full 3 months of voriconazole treatment, they had a much lower risk of developing an invasive pulmonary infection following transplant. They actually had 0 patients of the 36 that developed that versus 18% if they had a shorter course of voriconazole or didn't receive prophylaxis at all. So again, we have mixed results. If we're trying to look specifically at inhaled amphotericin B, this is all the data that we have. So it's not very robust, but there is information available, and you will have to just interpret that and see what you want to do as you individualize your care for your patients. As far as echinocandins are concerned, per the IDSA guideline, they are restricted as salvage therapy if your patient is maybe unable to take triazole antifungals, or it can be used in combination with other agents. However, maybe after our first session, we'll have to, in the words of Adam Grant, rethink that, as we now have Trikafta available on the market and the vast majority of patients that are using it. And so lastly, I just wanted to make note that, as you all may be aware, in the past 2 decades, there's been new classes of antifungal agents that have come out. I think the most recent one would have been in the last decade, isavuconazole, but that's still a triazole antifungal. And just like the growing bacterial resistance that's out there, as is the resistance for fungal organisms. And so here we have a laundry list. We've got a lot of different medications here. And the great thing about them is they are targeting new mechanisms of action. So we are not relying on the previous ones that we had and just adding to the bunch. We've got some new medications that are in the pipeline. So this may be options in the future if your patients are intolerant to triazole antifungals or if they have some resistance that is developed. So in summary, again, a reminder that the designation of colonization versus active infection of fungal organisms continues to be debated. So we have to consider the risk versus benefits of treatment on a patient-specific basis. The triazole antifungals voriconazole, itraconazole, and posaconazole are used as first-line treatment options for aspergillosis, and amphotericin B and echinocandins are reserved for salvage therapy or triazole intolerance. Consideration must be taken when selecting the triazole antifungals, and that's based on their adverse effect profile, drug-food or drug-drug interactions, and the need for therapeutic drug monitoring. And there are new antifungal classes on the horizon and currently in late stages of clinical development. And with that, I will take any questions.
Since we've established that the microphone isn't working, if anyone has a question, they can shout it out and we'll repeat the question from up here. In the meantime, I'm curious if the inhaled amphotericin B is still has the same problems with nephrotoxicity and electrolyte imbalances as you would expect with IV amphotericin B therapy.
I don't know the literature on that or if there is literature on that, but I would say that if you are administering drug locally, that it should decrease the amount of systemic absorption that you have. And so I think that it's really those high concentrations in the bloodstream that are then having to get cleared through the liver, through the kidneys, that are impacting the amount of nephrotoxicity and electrolyte disturbances that you have. So it should be minimal in my opinion.
I thought the amphotericin B prophylaxis study is really interesting. I didn't realize the rates were so high for the control group. Do you know if this is something that's been repeated with more sample sets or different therapies for the initial prophylaxis?
I'm not sure if it is being repeated for patients with cystic fibrosis, but there may be other patients that are receiving lung transplants that like collectively they are looking at that information, but there was not anything that I saw in the literature right now.
We have a question in the back.
Absolutely. So as far as resistance is concerned, I think you end up coming to a crossroads pretty quickly. So you've got your patient already on voriconazole or itraconazole or posaconazole. You've got, in my opinion, two options from here. Do I trial them on a different triazole antifungal and hope that they are able to maintain their efficacy and not fall victim to that resistance pattern? But also, like, is that logical? They do have the similar mechanisms of action, so what would make it such that this one is going to have a higher integrity than the other triazole antifungal? So that is one option. And again, thinking collectively of your patient and, you know, what other meds they're on and are they having some adverse effects to the triazole that they're currently on versus your alternative. And your alternative is going to be most likely, in my opinion, the IV amphotericin B. To be honest, I don't have too many folks that I send home on that medication. Usually it requires quite a few days of monitoring just to make sure that their electrolytes can keep up with it and we're not having to replete them. So it's not an absolute no, but then are you going to have to transition them to a facility or under some sort of direct observation in order to receive that however long duration that you choose to do your amphotericin B. So it is a really challenging spot. And I think you've just got to consider the patient as a whole and what, you know, which treatment option you think is better for them, along with engaging them in that conversation. And that one's going to be challenging, but you could also try one option and know that you have a second or third line option in reserve.
Okay, I guess we'll just thank Lauren.
Thank you.
So the final speaker in our session is Dr. Imogen Felton from Royal Brompton Hospital in the UK, and she's also a senior lecturer at Imperial College London, and she's going to talk about some examples of clinical cases in the UK, specifically on CF fungal infection.
Thank you very much. I hope you can all hear me. Thank you to the chairs for your invitation, and to the three speakers so far who've really paved the way for this final talk in the session to act, I think, as a Reader's Digest moment for us as CF clinicians in the room, because actually our role is to distill so many lines of noise and make beautiful, harmonious decisions for the patients in front of us. And our role really is to reflect the developments that the speakers have each covered so well, and bring in some of the really interesting and increasingly nuanced complexities into the clinical decision-making that we have to make with regards to the patients in front of us as they present in our clinics with different life stages and priorities, and often at odds with maybe fungal treatment, so that we can come up with some really robust strategies for shared decision-making in CF fungal disease. Just advance that. I've got no financial relationships to disclose here. I disclose, though, that this is a talk that is only going to focus upon pre-lung transplant CF fungal disease. That's a whole another 30 minutes at least. So it's, as I said, really quite a nice design of the talks today. And I don't think it's a happy accident. I think it is a design, because what we have here in front of us is an idealized international CF fungal MDT. And that's actually what we use in a more local respect at the Brompton Hospital in London, where we look after in the adult CF service just over 600 adults with CF. And on a monthly basis, we meet together with colleagues, both clinical and academic, to discuss these difficult, challenging, complex presentations of CF fungal disease alongside colleagues in immunology and my colleagues in non-CF bronchiectasis and host defense and severe asthma, with the invaluable input and expertise of infectious diseases consultants and mycology consultants, and the real, like, worth their weight in gold specialist antimicrobial pharmacists and CF pharmacists, and the procedural skill and expertise of thoracic interventional radiologists, the importance of which I'll come on to shortly. So that ultimately we end up with arriving at a consensus approach to really individualized, tailored treatment management decisions with the patient in mind, according to their patient characteristics. And that's really the goal, I think, and so important to consider in appreciating CF fungal disease in 2024 and going onwards. So in terms of the context of what's already been covered in some detail by each of the presenters already today, in regards the altered CF fungal landscape in light of the aging population and the impact, the direct impact of CFTR modulator therapy, I'm going to spend the next 20 minutes or so just focusing on 5 cases, 5 real-world cases that have all been through the Brompton CF fungal MDT service, so that we can see perhaps some updated patient profiles to act as archetypes for us to consider the spectrum that Carsten began talking about, from ABPA into active fungal bronchitis into cavitatory disease, and that tricky clinical categorization question. And I'll also talk about the vital job within this international CF fungal MDT that we have today to consider the balance of benefit and risk with regards to the patient characteristics in front of us, about choosing what, when, if, how long to prescribe or de-prescribe antifungal therapy, in particular with regards how we monitor for efficacy, but also how we monitor for specific side effect toxicities. First, do no harm. And actually, when we really consider antifungal therapy in 2024 going onwards, we must bear that in mind. And I'll also cover the impact and the burden of monitoring and actually the modality of monitoring, in particular with regards to radiation of antifungal therapy and fungal disease in CF. And I will cover some of the non-pulmonary biological niches that are increasingly important and are really worth bearing in mind, in particular with regards the rising number of women with CF who are considering parenthood and trying to conceive through pregnancy. So, on to the first case, and this is perhaps the most classic and easily recognizable or traditional presentation of CF ABPA, or is it? I mean, you can already see that we've alluded to that tricky clinical categorization problem of ABPA, allergy, into a more active Aspergillus bronchitis infection. And this case really represented for us several complications where we felt therapeutically thwarted at several points. And I'd like to share my pain with you today. So this involves a 17-year-old female who'd recently transitioned from the pediatric service at the Brompton into our adult service. And she has excellent, well-preserved lung function and spirometry and limited structural lung disease. And she presents to our CF nurse specialist with an insidious onset of breathlessness, some nighttime cough, some wheeze, and you can see here her baseline chest radiograph, and this is when we began to assess her. Her day one chest x-ray with some baseline serology. So Carsten will be looking at this because the eagle-eyed among you will see that she does not meet the criteria for the CFF minimal criteria foundation for ABPA, CF ABPA, because her total IgE is less than 500, but she has an elevated Aspergillus IgG. And it's a small representation of her day one chest x-ray there, but she's lost her left upper lobe. She's got a subtle collapse of her left upper lobe. And that alongside these rapid diagnostic fungal diagnostic tests that we use at the Brompton, which are really useful because we know that culturing Aspergillus and other filamentous fungi really does dictate and need 28 days at least. And we, sometimes we don't have that time, as I'll come on to. We need to make some therapeutic decisions. So we use a direct immunofluorescence stain, a calcofluor white stain. It just highlights the chitin in fungal cell walls, and it's cheap. And a cytology stain, Grocott methenamine silver. And we could see that in her sputum, it was chock full of fungal hyphae. And she had a sputum elevated Aspergillus galactomannan, and ultimately her sputum cultures were positive for Aspergillus. But what was really notable about her case was how rapidly and how severely she deteriorated clinically to type 1 respiratory failure with a successive collapse of her left, almost total collapse of her left lung, that warranted ultimately a critical care admission for intubation and mechanical ventilation to facilitate the bronchoscopic extraction of this really tenacious, almost, I don't know if you can see that, it was 10 centimeters, 4 inches long, bronchial cast, the characteristic bronchial cast that we read about in all of our textbooks. And that was removed intact with sustained suction and traction down the bronchoscope, and was clearly responsible for the successive collapse of her left lung. And in terms of the therapeutic challenges that we experienced with her case acutely, actually it predated it because this young girl had real difficulties in tolerating azole therapy for historic ABPA during her childhood. She had not tolerated itraconazole, she had not tolerated voriconazole, she had not tolerated posaconazole because of the toxicities that Lauren has previously spoken about. She'd also developed adrenal suppression because of concomitant prescription and administration with her ICS LABA inhaler that was a fluticasone containing preparation. So we were really stymied, but in the acute setting, we did need to treat with IV methylprednisolone and caspofungin, and yet further disasters. She developed accelerated hypertension related to that IV hydrocortisone and high-dose IV steroid with severe headaches. And ultimately, happily, I'm able to say she did respond, and we actually managed to get her onto isobuconazole. But what was really interesting was trying to seek a steroid-sparing way, in particular with regards to history. We found the greatest success for her was in the application of the monoclonal antibody, the anti-IgE monoclonal antibody, omalizumab. So brief aside from the case, this really highlights two important therapeutic considerations, which is the title of the topic here from a clinician's perspective. Firstly, that of the impact and the influence of inhaled corticosteroid usage in CF fungal disease and CF ABPA. And we have to bear in mind that these are people with chronic polymicrobial airways infection. And where there are people who are routinely on a daily basis taking in inhaled corticosteroids, in particular the potent fluticasone-containing combination inhalers, there is an increased risk that we've seen in case series data from asthma and in COPD, and in more recently from colleagues of mine at Imperial, mechanistic data to show that there is a lesser impact of innate immunity impairment with beclomethasone-containing preparations. And that, plus the fact that we know fluticasone concomitantly prescribed with azoles in CF fungal disease, there is a far greater risk of adrenal suppression. And so yet another reason for us to consider switching from a fluticasone to a beclomethasone-containing inhaled corticosteroid in CF fungal disease. But the second therapeutic point to consider in this case is, of course, the role for steroid-sparing immunologics, asthma biologics, the first of which was the anti-IgE therapy, omalizumab. And you can appreciate readily for people with cystic fibrosis who will want to limit the amount and the impact of steroids from a bone health and a prevention of osteoporosis development, but also in the context of CF diabetes and poor glycemic control. And indeed, biologics in terms of ABPA control for women who are considering trying to conceive in pregnancy, where we want to be avoiding high-dose steroids in a pregnancy, and we cannot use azoles. So potentially as a steroid-sparing and azole-remitting use, these biologic therapies are a really attractive target. And there's been a proliferation of these monoclonal antibodies from the severe asthma work, not just anti-IgE, but the anti-IL-5, mepolizumab. And that brings us on to the next case with a note of caution. So this is a 26-year-old man. You can see here 2 stop mutations. He is not eligible for ETI therapy in the UK. And he has a history of, 15-year history of ABPA. He routinely cultures Aspergillus fumigatus as well. But what he has is a really profound atopic asthmatic phenotype. I know asthma and CF, it's a bit of a controversial, contentious subject, but he has such variable airflow obstruction and really awful viral triggers for severe exacerbations, so much so that he's developed excessive dynamic airways collapse and has a malasic cough, so much so he develops cough syncope, and he had a road traffic accident because of this cough syncope. So he is steroid responsive, sadly steroid dependent, and he has adrenal suppression, osteoporosis, and has had cough rib fractures as well. So you can completely appreciate that we really sought a steroid-sparing therapeutic option for him. Unfortunately, he didn't respond really well with any significant signal for reducing steroids with omalizumab. And so he was started on tezepelumab. I'll come on to this. But within 3 weeks of starting, he developed a really significant and quite worrying sign of an invasive cavitatory fungal pneumonia here that you can see here after 3 weeks. Thankfully, after treatment with IV caspofungin, completely resolved and it remitted, that cavity shrank. So in terms of the choice of tezepelumab, and I'd be really interested, perhaps in our panel discussion afterwards, colleagues in the room who've previously had experience of this anti-TSLP immunologic therapy. It's a key epithelial cytokine that sits right at the top of the inflammatory cascade that has been shown to really be potentiated in the pro-inflammatory pathological response that drives severe asthma and high steroid usage, but in severe asthma, not in that of patients with chronic suppurative lung disease like in CF bronchiectasis. And he's chronically infected with Achromobacter, Xylus oxidans, and ESBL E. coli, as well as Aspergillus fumigatus. So given this case and 4 other cases from our service, as we discussed it in our Brompton CF MDT, we made the decision to withdraw and stop usage of tezepelumab as of last week, and have yellow carded and reported this as a really unanticipated and unwanted serious side effect. So a bit of a gear shift now from allergy and bronchitis into the third case I want to talk about, and again, drilling down on patient characteristics and our consideration of antifungal therapy. So this is advanced lung disease, and what Lauren was kind of talking about there, which was the impact of azole and ETI and the different dosing regimens. So we've got a 20-year-old male who pre-ETI had a very severe phenotype, both severe lung function impairment and really quite severe structural lung disease with established type 2 respiratory failure. He presents to us with a recent flare of ABPA associated with actually his taking up a job in a wood workshop. And he was established on isovuconazole because of the more favorable drug-to-drug interactions associated with ETI, and he continued on his 10 milligrams of prednisolone. But what's really notable here in terms of patient characteristics, and yes, his advanced lung disease, is he lives from an area of severe socioeconomic deprivation. And actually, in terms of his lifestyle and his housing, it was really quite chaotic, and it was often difficult to make contact with him, to see him reliably and regularly, and certainly his housing conditions were not that good. And that is really salient in his presentation, okay? So 5 days history of shortness of breath, fever, and a very rapid deterioration. He's brought in by his partner to the local hospital, not to the Brompton, where he's profoundly septic, multifocal consolidation here, and an established type 2 respiratory failure again. So a really good ED physician took a collateral history from his partner. He had not been taking isovuconazole. He'd not picked it up from the pharmacy, but he had continued to take the altered dosing of ETI. So essentially, he'd been underdosing, I think, his critical dependence upon ETI. And this really highlights our considerations when it comes to the impact of CFTR modulators, which of course are metabolized by the CYP3A enzymes, and azole concomitant prescription that have a CYP3A inhibition. And the patient in front of us and their ability to adhere to these complicated, changing dosing regimens. He had a very severe clinical course. He was actually retrieved by our VV ECMO team from his local hospital, brought to our ITU, and I'm happily able to say that by 29 days, having started ETI therapy and caspofungin again, he made a miraculous recovery. He was decannulated by day 15, and we have started the lung transplant assessment workup. He still remains on the active watch and wait lung transplant list, and it's really well. A bit of a gear shift, but still into advanced lung disease and the impact of ETI and adherence, but this time in a non-pulmonary fungal biological niche. So this is a 37-year-old female who is on ETI and is already on the watch and wait lung transplant list. And she has still really quite a significant severe lung function impairment and structural lung disease with mucoid pseudomonas chronic infection and type 2 respiratory failure. But significantly, in relation to her severe pulmonary, established type 2 respiratory failure, she has cardiac comorbidities already. So that's important when we consider antifungal therapy. And we need to consider antifungal therapy because she's been treating herself with antifungal therapy unbeknownst to us. She's had recurrent and refractory vulvovaginal thrush and had been taking over-the-counter fluconazole alongside ETI for some time. And finally, she was either asked and or spoke to us about this really disabling condition that she'd been suffering with for 6 months or so. So we referred her to our colleagues in sexual reproductive health, and they wanted to intensify her fluconazole treatment, essentially by giving her 150 milligrams of fluconazole twice a week. And our specialist antimicrobial pharmacist said, well, okay, this is going to act as sustained CYP3A enzyme inhibition. We have got to reduce her ETI regimen to twice a week. Now, in relation to the case that we've just spoken about, has she got critical dependence upon effective ETI and CFTR restoration? Very potentially, yes, she has. The decision was taken out of our hands, and actually, when she was brought in for optimization for IV antibiotics, we added in IV caspofungin, and so we didn't have to alter her ETI regimen, and her symptoms completely resolved. So this just highlights the important considerations, again, for these patient characteristics in front of us, individualized patient characteristics in front of us. We have to consider their physiological reserve as well as their social reserve, the social determinants of health, when we talk about complicated ETI, dosing regimens, and the DDIs, and in particular, cardiac toxicities. So in terms of ensuring regular monitoring, in terms of antifungal stewardship, we really should be looking at a bidirectional impact, especially when we're thinking about ETI. So yes, we should be surveilling, in particular, people with CF who have advanced lung disease and are on azoles. And we need to think about regular and robust ways to surveil for therapeutic drug monitoring in order to avoid antimicrobial resistance of these fungal isolates. But we also have a program where we are routinely and now prospectively establishing effective sweat chloride. We have no therapeutic drug level for ETI yet. And so we're looking at other markers. So we're looking at sweat chlorides, perhaps even before a switch from posaconazole to isobuconazole. And those things are really worthwhile taking forward, I think. The final case that I want to end on is not fungal bronchitis or allergy, but now cavitatory disease, in particular cavitatory fungal disease and the risk of hemoptysis in the context of pregnancy. I don't think it gets more complicated. I mean, it probably does, but it was a real challenge. So this is a 32-year-old woman, F508 del homozygous, who had post-ETI a really quite well-preserved CF lung function. 70% predicted or thereabouts, fully independent, running her own business, but a history of recurrent scedosporium infection with normal serology. She's not on any baseline steroid, but she has no elevated specific RAST to scedosporium, normal total IgE. And in terms of her history, the most salient features here are that of a real difficult and recurrent, frequent history with moderate to large volume hemoptysis, requiring several episodes for bronchial artery embolization. Now, these episodes of moderate to large volume hemoptysis had been less frequent on being established on ETI, as well as daily isobuconazole and cyclical caspofungin for this cavitatory risk. So she's treated with combination azole and cyclical caspofungin. And she presents to us today because for 10 years, she and her husband have delayed in starting a family, and it is all that they have wanted to do. And the decision for us to take together is, how do we safely deprescribe azole therapy, which is not safe in pregnancy? Well, we absolutely keep her ETI going, and I'm very glad to talk about the results there in terms of potential innate antifungal impacts. So I'm happily able to say that she had an uncomplicated pregnancy and delivered vaginally, spontaneous labor, baby Jessie here at 39 weeks. But nearly 14 months in total of no antifungal treatment. And these are her CT scans at 14 months, which was associated with the recurrence of hemoptysis. And I think you can appreciate there's been an evolution, a development, a progression of her CF cavitatory mycetomata. And so she was restarted on cyclical caspofungin with additional terbinafine and isobuconazole, which relates to her sensitivity profile and some synergy in terms of scedosporium, and alternate day ETI. And we assessed the efficacy of her ETI therapeutic drug monitoring so far as we can, and she still had a suppressed sweat chloride. So that was quite useful. In terms of our learning from this case and going forward, where I work in the CF Maternal Health Service, it's merely made us consider antifungal treatment in pregnancy as well, and the monitoring of cavitatory CF fungal disease that is not reliant upon CT radiation, but actually on non-radiation lung MRI imaging, and you compare these in particular to see the mycetoma, which are visible on CT. These are appreciable on T1-weighted MRI imaging. And another really handy feature of MRI imaging is you can appreciate a right-to-left shunt in terms of the hemodynamics, and potentially that can act as a risk profile for a further episode of hemoptysis, in particular during a pregnancy where there is such change in cardiopulmonary circulation and circulatory volume. So potentially even guiding the choice to perform a prophylactic BAE for women who are potentially planning a pregnancy. So in summary, there are so many more variables to consider now according to the individual patient characteristics in front of us when we consider antifungal treatment therapy. Understanding those individualized physiological and social characteristics can really help us make the choice between harm and benefit in terms of prescribing or deprescribing antifungal therapy. I would really commend the benefit of having an ID, specialist pharmacist, specialist thoracic radiologist, MDT approach to these treatment decisions so that you can have a robust surveillance measure to check for treatment efficacy and toxicities. And of course, there is a real need now in this changed landscape for well-designed prospective cohort trials. So I'd like to acknowledge my huge thanks to the patients that have allowed us to share their cases today, and to my colleagues at the Royal Brompton Fungal MDT, Darius Armstrong-James and Anand Shah, among others. And I would like to acknowledge the support of the CF Trust, who support the terrific targeting immunotherapy for fungal infections in CF that Darius runs, and a shout out to our new Matriarch CF Strategic Research Consortium that begins in the early part of next year, and that I'm leading with Jane Davies, and is a prospective study of, certainly we'll be looking at fungal infections in CF and the impacts of pregnancy and ETI therapy in offspring. So thank you so much for your attention, and I'm happy to take questions alongside the panel at the end.
Great. Thank you for an excellent presentation. I guess we'd first like to invite all the speakers up. Start the panel discussion. And in the interim, if anybody has questions specifically, the microphone is, so we can happy to share. Yep.
I think the question was about what are the putative mechanisms of tezepelumab being associated with some of the changing cavitatory responses that we've seen in all of 5 cases. Okay, so it's a really small number, and we're being very cautious to pause and withdraw that. But I think it's because of its role. This thymic stromal lymphopoietin has clearly such an upstream impact on innate immunity, where there are potentially really difficult infections, not just with fungal species, but also the gentleman that I presented there has an ESBL E. coli as well. I think we need to be quite cautious at this moment before we we move away from trying to use targeted anti-IgE monoclonal antibodies. That would be my one note of caution. Was that a question about sensitivity profile testing for fungal isolates? Can I hand that over to Jane? Yes, there's a mycology reference lab that we use in Bristol in the UK that will, I mean, it takes time, but we can appreciate sensitivity profile testing against a panel of commonly used antifungal agents. Yeah.
Maybe the question is also a little bit similar to a bacteria, where we are usually not using the susceptibility testing because we know there are different Pseudomonas bacteria and we can't transfer the results to our patients. In fungal diseases, we don't know it actually. The data are not existing. But I think it's very important not only to do it once at the beginning when you start the therapy, but repeat it, because sometimes fungi will get very, very quickly resistant, and then you might think about changing the therapy. That's, I think, very important.
So the way we had this session was, I think, almost a 50-50 split between early diagnosis and then also treatment. But clearly, with all the drug interactions, there's going to be some big issues in terms of azoles. How optimistic are you in terms of like the pipeline for future antifungals and how much that is needed currently? Because yes, we've some in development, but they appear to be a bit further out.
My best guess is that it's going to be another decade. Right now, I think there's 2, if not 3, of the new agents that have received FDA approval. But this is going to be for skin and soft tissue infections, for vulvovaginal candidiasis. So, of course, as the natural progression is we start with infections that I would say are lower in morbidity and mortality to get that initial FDA approval, and then it's expanded upon. That's probably also, I don't know, maybe close to a decade in of them having done their research, and now we're in those phase 4 trials. So I do think that it's encouraging, but I just think that we're still going to have to be patient, and we're going to have to wait a while and make some really challenging decisions in the interim.
I would like to ask the question to the panel, but also you in the audience. So, I mean, what would we have to do when we are treating the patients with posaconazole? We have to reduce Trikafta. And we experienced that with 2 tablets twice per week, it's not enough for the patients. I mean, we are still having not the levels of ETI, so we don't know what to do. But the patients usually say, okay, if I only take these 2 pills twice per week, I have more sputum than before. So we switch to 3 times, sometimes even 4 times a week. So that's something, I don't know, if you also experience it, I think it's very important because the recommendation is really, if you have a strong CYP3A interaction, to reduce it to twice per week.
We've also done the same. Patients who describe the seesaw chest, where they may take their ETI on a Monday and a Thursday, and Tuesday and Wednesdays are just disasters. So there clearly is a waning impact, and rather than necessarily switching straight to isobuconazole, which yes, it has favorable DDI profiles, it's expensive, and it doesn't suit everybody. So we often switch, and we do baseline and then prospective sweat chloride testing, and obviously liver function enzyme testing. But we may switch to alternate day dosing regimen with posaconazole with good effect. In the MDT approach, we meet monthly, we have to decide. We say, okay, we've done 3 months, we've done 6 months, we're going to trial a stop because of the significant cardiotoxicities. I think that's the one thing that really makes us concerned in particular. So yes, with echo surveillance, but we have to draw a line somewhere. So in terms of the cyclical echinocandin therapy that we do for invasive or mycetoma therapy, we often will do 6 months of treatment and then establish a review of treatment with a constellation of radiographic science, serology, and clinical course. And then we'll call a pause 6 to 12 months in terms of mycetoma.
maybe I can add something. I would say depending on the fungus, so is it Aspergillus or is it Scelosporium? And Scelosporium usually have to treat not only with one drug, but maybe with 2 or even 3, and much, much longer with 1 or 2 patients where we're treating. Then I think we never stopped it, because when we stopped it, she was getting worse. So 2 women. And the other thing is depending on the entity. So if there's a mycetoma, I would also be very, very anxious to stop the therapy, because usually in other patients we would maybe perform surgery. And so I think it's really depending on the individual case, but sometimes I would treat it longer than shorter. That's the experience, because sometimes we have severe hemoptysis when we stop the treatment, and then we have a recurrent infection. So I think the message should be, please treat it longer, preferable compared to shorter treatment. That's what we think.
I think of the cases that I spoke about, they were all combination treatments, different modalities of antifungal treatment. I mean, which you would absolutely appreciate as a microbiologist. So yes, and it will change according to the different prime driver of their disease, be that antifungal, their life stage, their different priorities. It's an incredibly dynamic set of variables at any one time.
Is that, though, right off the bat that you start with the 2 agents, or is that after they've failed a course of monotherapy that was appropriate?
I was just going to make a quick comment about how some of the studies at Dartmouth in the Kramer lab and in our lab show heterogeneity among isolates in a single infection in terms of drug resistance, or the presence of multiple strains of Aspergillus, I believe, in the Kramer lab. And so that might be something to consider, I guess, in thinking about monotherapy versus combination therapy.
I mean, we have not only one, we have several cases, and I mean, it's depending also on the patient, because if you have side effects, and we usually try in those cases to combine the therapy with an systemic therapy, so oral posaconazole, for example, and then inhaled amphotericin B, for example, because we think, in particular, if you do a bronchial, no, not lavage, you did this blockage of the vessels, so arterial and embolization. So that's a word. Sorry. There won't be any possibilities to get the drug in there. So that's why we always, in those cases, try to give them the inhalation. But that's usually also not well tolerated over 6 or 7 or 8 months. But that's how we try. And then we might change again back to other therapies. So that's never one way. But those patients, I think, to clear it, it takes maybe years. And yeah, I don't know if you can stop at a certain time. I don't know. I mean that's the problem. That's why I said I would test it more often if you treat it long. But at the end, I mean, it's very important if you use an azole, for example, to really measure the serum level and see that's always high, because that's, I think you showed the study, 43%, and when you measure it, they are not in the adequate level. That's a problem. Yeah, and I think if you're using inhaled therapy, in addition, you have a very, very high amount of drug in the lungs, and so the likelihood to get resistant fungi is much lower. Yeah.
Great. Despite the fact that this is a great discussion, the time has come to an end. So let's thank our speakers for a really wonderful session one more time.